Hello everyone, I am Elena Creuhá and I'm a pediatrician. I work in pediatric gastroenterology and nutrition at Clínico Hospital of Valencia. And we're going to continue talking about granulocytoapheresis in pediatric inflammatory bowel disease. I'm going to talk about a case we had at our centre that differs slightly from the usual indications for this technique. I present a 14-year-old adolescent, clinically referred for a month and a half of bowel movements, 3 to 8 times a day of liquid consistency, with blood and mucus, some of them with rectal tenesmus, and urgency to defecate, also associated with abdominal pain and asthenia. There were not many relevant data in terms of his personal as well as family history. He had a maternal cousin with ulcerative colitis, and he had no relevant history. At the beginning, as for his nutritional status, it showed that he had good nutritional status. Skin pallor was observed, and he presented pain upon examination of the left iliac fossa and increased peristaltis. In this case, further complementary examinations were performed at that point. The complete blood count was normal during examination, mild microcytosis with low ferritin levels, negative parasitological examinations and stool cultures. Very high fecal calprotectin was observed. In the emergency department, different examinations were performed, an ultrasound that at that point was normal, and different tests that already considered and pointed towards being a suspected case of inflammatory bowel disease. He was admitted to the ward where examination was completed with an endoscopy that confirmed the diagnosis of ulcerative colitis. At that point, it was ulcerative proctosigmoiditis, with active moderate ulcerative colitis and a POCAI of 60 that corresponds to a moderate flare-up. He was therefore admitted in the hospital at that point, and as a moderate flare-up, treatment was initially started with mesalazine administered both orally and rectally with a good initial response. The POCAI decreased, the response was good, the reagents remained low, and he was discharged. Following his progression since discharge, he was reviewed in consultation every week. The patient remained asymptomatic, but after 14 days, he had liquid bowel movements again with blood, which is why it was decided to start oral corticosteroids. 3 days later, he kept worsening. It prompted his admission, and he was associated with a POCAI of 70, now indicating a severe flare-up, in keeping with the clinical guidelines. Mesalazine, administered both orally and rectally, was discontinued just in case it was due to an intolerance, and intravenous corticosteroids were started. At this point, the ultrasound showed progression with sigmoid colon and colon structure, including C-col wall thickening, increased vascularization, data that corresponded to a pancreatitis. There was no response to intravenous corticosteroids. The POCAI remained at severe flare-up. Infliximab therapy was started at that point, at an increased dose with intensive regimen, with adequate blood levels but without any response. The POCAI remained severe, 15 to 20 bowel movements a day with mucus, profuse blood, and required transfusion. So, looking at what the guidelines say in this case, they recommended us to proceed to third-line therapy. In severe cases, with flare-ups of this severity, we need to consider colectomy. At this point, we were considering whether to go for surgery, what other therapeutic options we could consider. The option of starting granulocytoapheresis arose at that point, which, as they told us before, is reported more in corticosteroid-dependent or corticosteroid-refractory colitis. And at that point, we had scarce experience in pediatrics. But there are other scenarios where it could also be useful. In this case, it would be the failure of biologics and other therapies. In this algorithm, we can see that our patient would correspond more to the flare-up on the left of corticosteroid-refractory cases and also anti-TNF failure, but is covered by mild or moderate flare-ups, and our patient was a severe case. We would not be in the usual indications for this technique. In the process, as it has already been mentioned, normally 2 peripheral lines are inserted, and the blood circulates via a pump and then proceeds to the column, which filters it and returns to the patient. Let us say that, in this case, apheresis is selective, and primary filters, granulocytes, low percentage of monocytes, some very few lymphocytes. It is like that due to the mechanism of action, which filters immunocomplexes, immunoglobulins, and these cells that adhere to the column the most are those that have the same receptors. It is a technique that has scarce contraindications. It has a good safety profile. So, as has been mentioned, in pediatrics, we would not have any growth-related or immunosuppression-related adverse events. Therefore, it is interesting in the pediatric population. Normally, we perform a traditional regimen, which is 1 weekly session for 5 to 10 weeks. But in the case we are considering, as it was a severe flare-up, we decided to start an intensive regimen, 2 weekly sessions for 3 weeks, and then maintain 1 weekly session for 4 weeks. That way, we aim to reduce the response time and to make the effectiveness consequently faster. Here is the progression of our patient. You can see the progression both via CRP and the Creuhá, which is the clinical score. And we can observe that with corticosteroids and infliximab, first dose of infliximab, second dose of infliximab, we did not get any response. Nevertheless, after starting leukocyte apheresis, we had a very good response when CRP started to decrease and the Creuhá started also to decrease. Subsequently, we were able to reduce the corticosteroids dose until they could be gradually withdrawn. Infliximab remained in the usual regimen. The blood levels were monitored, and little by little, it began to work. And the leukocyte apheresis was maintained until a total of 10 sessions were completed. After discharge, the patient had initially severe MARD incidences. After 3 months, he had an episode of abdominal pain with soft bowel movements, in which a new rescue therapy session was started, combined with rectal budesonide. And subsequently, after 4 months, he remained asymptomatic and underwent a follow-up colonoscopy, in which his ulcerative colitis was noted to be quiescent. I have already told you this technique is normally applied in corticosteroid-dependent, corticosteroid-refractory patients as bridge therapy. Nevertheless, its use in severe flare-ups is not that clear because its onset effect is slow. But we have found some other published cases in which it was also used in similar cases to ours. The key message here to take home with us is that granulocytoapheresis is a safe technique that has few side effects. It may have some additional advantages such as avoiding adverse drug events, and above all in pediatric patients, there are some clearly established indications, such as corticosteroid refractory situations, corticosteroid dependence, bridge therapy, but the case I presented to you constitutes a severe clinical presentation, and, in our case, we believe its use spares us a colectomy. In some cases, we could consider it always an intensive regimen so that it has a better effect as rescue therapy in cases which do not respond to other therapies. And that is what I wanted to tell you. Thank you very much for listening.